Ophthalmic examination. The objectives of this video are to demonstrate how to do a complete ocular examination in small and large animal species. There are some important technical aspects to note prior to beginning the ophthalmic examination. The examination should be performed in a quiet room that can be darkened to minimize distractions and interfering reflections. There are some basic equipment and supplies that are required for a complete examination. These are a transilluminator, an indirect fundoscopic lens, a direct ophthalmoscope, magnifying loops, Schirmer tear test strips, a tonometer, topical mydriatic agents such as tropicamide, fluorescein stain, topical ocular anesthetic drops such as proparacaine, sterile eye wash, and culture swabs. Advanced specialized equipment such as a biomicroscope is beneficial in that it allows for more magnification and thus a more detailed ophthalmic examination. However, this instrument can be expensive and requires more skill to become comfortable in its use. For fundoscopic examination, an indirect ophthalmoscope headset permits stereoscopic viewing of the fundus compared to a transilluminator and lens. This is a nice instrument to have, but it can also be costly and therefore is not always available to the general practitioner. Proper restraint and positioning are essential for a good ocular examination. Chemical restraint is commonly used in the examination of large animals, but rarely needed for small animals. Small animals should always be examined on the table, in a sitting position, or in sternal recumbency. In large animals, a thorough ocular examination usually requires sedation and regional nerve blocks, and these will be discussed in more detail later. Administration of eye drops is a necessary part of the examination. These will include the administration of mydriatic drops to dilate the pupil and may include administration of topical anesthetic eye drops. To properly administer topical ophthalmic eye drops, the animal's chin should be held up with the non-dominant hand. The dominant hand administering the drops may be rested on the head, and the bottle is held far away from the eye to avoid contact of the bottle to the eye. The administrator's fist can be used to pull the upper eyelid skin back, which will help keep the upper eyelid open. The bottle is given a gentle squeeze, allowing one drop to land on the eye. Administration of eye drops in the horse is more technically difficult as you need to avoid contact of the bottle with the animal's eye. 0.3 to 0.5 milliliters of medication can be drawn up in a 1 milliliter syringe. The lower eyelid can be rolled out and the administration completed by squirting the liquid into the ventral conjunctival fornix. Alternatively, a 25-gauge needle can be attached and the needle portion removed at the hub by rolling within the needle cap. This can then be used to spray the cornea from a distance. Administration of more than one drop is not necessary in the dog and cat. The equivalent of about 2 to 3 drops can be administered in the horse due to the larger surface area of the cornea. The ophthalmic examination may be divided and organized into 5 components, and these should be completed in sequential order. These are the distant ocular examination, the neuroophthalmic examination, ocular diagnostic tests, Mydriasis, and orbital, adnexal, and intraocular examination. It is essential that both eyes be examined for a complete ophthalmic examination, not just the eye that appears to have a problem. The first component of the ocular examination is the distant ocular examination. The ophthalmic examination begins with observation of the animal at a distance. The animal's attitude, behavior, and ability to navigate in an unfamiliar environment should be closely observed. Observing the animal as it walks into the examination room is the beginning of the distant exam. Next, from a distance, one should evaluate the conformation and symmetry of the face, eyes, and adnexa. Assess the size of the globes, the position or direction of the globes, and the periocular structures and orbits for obvious abnormalities. When directly facing the animal, the eyes should be observed simultaneously from a distance of approximately 3 to 5 feet, eliciting a fundic reflection to illuminate the pupils, i.e. retroillumination. This allows assessment of pupil size, shape, and symmetry, and aids in determining eye position. The second component of the ocular examination is the neuroophthalmic examination. The neuroophthalmic examination evaluates cranial nerves through the menace response, the direct and consensual pupillary light reflexes, the palpebral reflexes, the dazzle, and the vestibular ocular reflexes. In large animal species, it is important to complete the neuroophthalmic examination prior to administering sedation and regional nerve blocks. The menace response. This response is evoked by making a menacing gesture towards the animal's eye with one hand, while the other hand covers the contralateral eye. If the animal can see, it should blink. It is important to always cover the other eye, as animals that are unilaterally blind will observe the motion with the normal eye and respond with a bilateral blink. It is also important to not touch the patient or create excessive air currents, as this may stimulate tactile hairs on the face and can elicit a false positive result. The large vibrissae in horses are very sensitive to air currents, and the examiner should be extremely careful to avoid touching these. The menace response is a learned cortical response and therefore may not be fully developed until 12 to 16 weeks of age in some small animals. Pupillary light reflexes. The direct pupillary light reflex is a subcortical reflex elicited by shining a bright focal light source into one eye while observing the reaction of its pupil. In a normal animal, prompt pupillary constriction should occur. This is repeated for the contralateral eye. The consensual pupillary light reflex is also known as the indirect pupillary light reflex and is evaluated when the examiner shines a focal bright light source into one eye while observing the reaction of the contralateral pupil. The normal response is pupillary constriction in the contralateral eye. Due to lateral placement of the eyes in large animal species, an assistant is required to evaluate the consensual pupillary light reflex. The assistant illuminates the globe without stimulating the reflex in order to visualize the pupil, while the examiner shines the bright light in the contralateral eye. Pupillary light reflexes in the horse are generally slower than those of small animal species. Palpebral reflexes. The reflex is elicited by touching the medial and lateral canthi of both eyes, and the response to the touch should be a blink. It is important that the animal does not see the clinician's finger approaching the canthus, as if this is the case, the animal may blink because it sees the finger, not necessarily because it feels the touch. Dazzle reflex. This reflex is initiated by shining a bright focal light source, such as the transilluminator, on full brightness into the eye. This should result in a partial blink or squinting response of the eye. Vestibular ocular reflex. This reflex is also known as the oculocephalic reflex and evaluates the ability of the eyes to remain fixated on an object while the head moves. The reflex is elicited by slowly moving the patient's head from side to side and observing the limbus to note the resulting eye movement. These lateral movements of the eye are known as the normal physiological nystagmus. This reflex is also tested by moving the patient's head up and down and observing the vertical and ventral motions of the globe. The fast phase of the reflex is in the direction of motion. The third component of the ocular examination is the diagnostic ocular tests. The ocular diagnostic tests that should be completed with every ocular examination are the Schirmer tear test, tonometry, and fluorescein staining. The Schirmer tear test. The Schirmer tear test should be performed before any topical medications are placed in the eye, as topical medications will alter the Schirmer tear test value. This test uses sterile absorbent paper strips to measure aqueous tears. To perform the test, the notched end of the strip is folded while the strips are still in the packaging to avoid direct finger contact. This avoids grease or oil contamination of the strip from the examiner's fingers. The strips are then removed from the packaging, grasping the strip from the end opposite the notch, and the folded end of the strip is then hooked over the eyelid and placed in the ventrolateral conjunctival fornix of the eye. Strips are left in place for a total of 60 seconds. If blinking or retention of the strip during the test becomes a problem, the lids may be closed gently for the duration of the test. After 60 seconds, the strip is removed and immediately placed on the measuring gauge provided on the original package to measure the amount of wetting in millimeters. Schirmer tear test strips are also available that are impregnated with a blue dye that marks tear migration in millimeters directly on the strip. Tonometry. Tonometry is the measurement of intraocular pressure and is an essential diagnostic test in all ocular examinations and should always be done in both eyes. There are 3 basic types of tonometry used in veterinary medicine: indentation, applanation, and rebound. Proper restraint is absolutely essential while performing tonometry, as excessive restraint will falsely elevate intraocular pressures. Therefore, the clinician must ensure that the patient is not struggling, that the jugular veins are not being occluded, and that the eye is not being compressed while performing tonometry. The exact position will depend on the method used. However, restraint of the head should occur by holding below the jaw to avoid neck pressure. In large animal species, the auriculopalpebral nerve block should be performed prior to tonometry to reduce pressure on the globe from the eyelids. Additionally, sedation and an elevated head position are recommended for tonometry in the horse. Indentation tonometry. This is the form of tonometry that uses the Schiot's tonometer to measure the extent of indentation of the cornea. The Schiot's tonometer is a relatively inexpensive instrument that has 3 main pieces: a threaded pin, a main handpiece with scale, and weights. It is assembled by placing the threaded pin into the cannula of the main handpiece and screwing the 5.5 gram weight plate onto the threaded end of the pin. The additional weights provided allow for total weights of 7.5 and 10 grams. These weights are added to the top of the 5.5 gram weight only when high intraocular pressures are measured, as they will increase the accuracy of the measurement when the intraocular pressure is greater than 30 millimeters of mercury. Before the Schiot's tonometer is used on the patient, it should be calibrated on the convex metal test cornea provided with the tonometer. With the 5.5 gram weight in place, the Schiot's tonometer is held by the side holding brackets, and the foot plate of the tonometer is rested perpendicularly on the metal cornea. A reading of 0 should be obtained, which ensures that the reading needle has not been bent and that the instrument is functioning properly to perform tonometry in the patient. Next, the patient's cornea should be anesthetized with 1 to 2 drops of topical anesthetic. After an approximately 30-second delay to ensure corneal anesthesia, the footplate is placed perpendicularly on the surface of the cornea. Because the plunger is gravity-driven, the tonometer must be positioned perpendicularly to the cornea to provide an accurate reading. Therefore, proper head position to allow the cornea to be in a horizontal plane is essential for obtaining an accurate intraocular pressure estimation with the Schiot's tonometer. The head of a large dog is held nose up to the ceiling by an assistant while the examiner gently holds the eyelids open without placing pressure on the globe. Occasionally in small dogs and cats, it may be easier to place the animal in dorsal recumbency so their nose will point up to the ceiling and their corneas will be in the horizontal plane, allowing the tonometer to be lowered perpendicularly onto the cornea. Once the tonometer is placed on the cornea, the holding brackets are slid down to approximately the middle portion of the cannula. This allows the weight of the instrument alone to rest on the cornea and ensures that the examiner is neither pushing the tonometer onto the eye nor lifting it off. Initially, the examiner will note that the needle will move back and forth for the first 1 to 2 seconds, and then it will sit still. This is the point that the reading is taken and the tonometer is removed. This entire procedure should be repeated 3 to 4 times, and the readings obtained should be averaged. It can often be helpful to have the assistant who is restraining the animal watch the needle and take the readings. This allows the examiner to gently hold the eyelids open and to focus on proper perpendicular placement of the instrument on the cornea. The intraocular pressure is then obtained from a table that converts the scale reading from the tonometer to the intraocular pressure via the appropriate weight column. The Schiot's tonometer should be disassembled and cleaned after each usage to ensure that it is free from debris, which can inhibit plunger movement. Applanation tonometry. This form of tonometry measures the force necessary to flatten a given area of the cornea. The intraocular pressure is then calculated from the force measured. The Tonopen is a commonly used handheld applanation tonometer in veterinary practice that is accurate and can easily be used to measure the intraocular pressure in most species. Prior to applanation tonometry, topical anesthetic should be applied to the cornea as per indentation tonometry. The tip of the instrument should be covered with a disposable latex protective cap to ensure sterility and prevent tears from wicking up the plunger. The technique is best performed with the patient in sternal recumbency and minimally restrained with the neck position 90 degrees. The applanation tonometer is held perpendicular to the cornea, while the instrument tip gently contacts the cornea several times in succession. As each reading is taken, a quiet beeping sound is heard. And finally, a louder beep is heard when several readings have been taken and averaged. The final averaged intraocular pressure is then read directly from the instrument. Conversion tables are not required. Applanation tonometry should be repeated until the reliability of the reading is within 5%. Rebound tonometry. Rebound tonometers assess the interaction of a small metal probe as it strikes the cornea and rebounds back to the instrument. This is also a very accurate method of estimating intraocular pressure, and it has the advantage over indentation and applanation tonometry of not requiring the use of topical anesthesia prior to using the instrument. To perform rebound tonometry, the tonometer is held a 1/4 inch from the corneal surface, and each time the button on the instrument is pushed, the small probe rapidly reaches out to touch and rebound off the cornea. Several measurements are taken, and a small beep is heard when each successful reading is obtained. Once 6 readings have been taken, a longer and final beep is heard, and the final average reading of intraocular pressure is displayed. Fluorescein staining. Fluorescein dye is a water-soluble dye which can be used to detect corneal or conjunctival ulcers and to assess the patency of the nasolacrimal system. Due to its lipid insolubility, fluorescein does not penetrate the intact corneal epithelium. When epithelial erosions or ulcers are present, the hydrophilic corneal stroma is exposed, which allows penetration and retention of the dye. This is visible as a bright green stain on the cornea. Several methods can be used to apply fluorescein dye to the eye. However, the recommended method is to moisten the strip with sterile eye wash, and then to very briefly apply the moistened strip directly to the dorsal bulbar conjunctiva. Direct contact of the strip with the cornea should be avoided, as it will result in artificial stain retention. Some clinicians will place a fluorescein strip in a 3 milliliter syringe with a small volume, 0.5 to 1 mL, of sterile saline wash, and then drop the fluorescein solution directly onto the cornea. This is an acceptable method for fluorescein staining, assuming that the dye is not diluted in a larger amount of fluid, as fluorescein dye that is too dilute can result in a false negative test. With either method, it is then recommended that the fluorescein dye be immediately and vigorously washed away from the surface of the eye with sterile eye wash. The surface of the cornea and conjunctiva are then examined in a totally dark room with a cobalt blue filter on the ophthalmoscope or a Woods ultraviolet lamp. This light promotes fluorescence, which enhances the clinician's ability to identify small corneal or conjunctival ulcers. To evaluate nasolacrimal patency, the nares and pharynx can also be examined with the cobalt blue or ultraviolet light. With a patent nasolacrimal system, dye will be present in the ipsilateral nostril within 5 to 10 minutes in small animals and up to 20 minutes in large animals. This test for patency is also known as a Jones test. The absence of dye passage, however, does not necessarily mean nasolacrimal duct obstruction. Once the neuroophthalmic examination and ocular diagnostic tests are completed, it is important to instill drops to achieve mydriasis. Mydriasis is necessary for a complete ocular examination of the lens, vitreous, and fundus. The presence of a dilated pupil also aids in retroillumination, which is essential to highlight lesions in clear media such as the cornea, aqueous, lens, and vitreous. Most mydriatics take approximately 20 minutes to have an effect, and so to conserve time in an appointment, it is recommended they be given early in the examination. The mydriatic of choice is 0.5 or 1% tropicamide, as it has a rapid onset of action, approximately 20 minutes, and a short duration of action of 2 to 4 hours. 1 drop of mydriatic is placed on the cornea of each eye, and after approximately 20 minutes, the pupils should be sufficiently dilated for intraocular examination. While awaiting for mydriasis to occur, the orbit, adnexa, and anterior segment can be evaluated. The fifth and final component of the ocular examination is the orbital, adnexal, and intraocular exam. This includes the fundoscopic examination. The main instrument utilized for this portion of the examination is the transilluminator as a light source. Head loops are also useful for magnification during several steps. Systematic examination is critical in the examination process, and to remain systematic, the ocular examination is best completed from anterior to posterior. We begin with examination of the orbit and gradually move posteriorly in the globe. For orbital examination, the symmetry and position of each globe is evaluated closely from varying angles, from directly central, top, and from the side of the animal. This is followed by palpation of the orbital rim. Gentle retropulsion of the globe simultaneously through the closed eyelids should be performed to compare compressibility between the orbits and to assess for pain. Retropulsion is contraindicated when deep corneal ulcers or corneal foreign bodies are present. In animals with suspected orbital disease, such as infection, neoplasia, or trauma, mandibular manipulation may induce pain or resistance, and once the full ophthalmic examination is completed, the oral cavity should be examined for abnormalities. Eyelids and third eyelid examination. Using the transilluminator, the eyelids, eyelid margins, and canthal regions should be examined. If ocular discharge is present, it should be described. Any abnormalities of the periocular skin should be noted. Palpebral fissure size, eyelid position, and disorders of the cilia such as trichiasis and dystichiasis should be noted. The meibomian or tarsal gland openings should be examined for masses or protrusions. The third eyelid, also known as the nictitating membrane, should be examined for protrusion, inflammation, scrolled cartilage, prolapses of the gland of the third eyelid, masses, or foreign bodies. Manual retropulsion of the globe by placing gentle pressure on the dorsal aspect of the eye will cause protrusion of the nictitating membrane to allow for complete examination of its anterior surface. In some cases, such as corneal ulceration, the bulbar aspect of the third eyelid may need to be examined. This can be performed by applying some topical, local anesthetic and grasping the third eyelid with forceps to reflect it anteriorly for examination. Nasolacrimal puncta. Examine the dorsal and ventral puncta in the palpebral conjunctiva. These are located approximately 2 millimeters lateral to the medial canthus. Loop magnification is helpful for examination of the puncta. In some animals, a small amount of pigment along the margins of the puncta will facilitate identification. Conjunctiva. Gently evert the eyelids and examine the conjunctival lining of the eyelids, the palpebral conjunctiva. This includes evaluation of the meibomian glands themselves. Loop magnification is helpful for examination of the meibomian glands and to evaluate for ectopic cilia, which may be seen in the region of these glands. Retract the lids and examine the conjunctiva lining the anterior globe, the bulbar conjunctiva. Abnormalities such as chemosis, hyperemia, thickening, follicles, or masses should be recorded. Sclera and episclera. Underneath the bulbar conjunctiva lies the episclera, an anterior aspect of the sclera. The clinician should examine these structures for changes in color, thickness, or for masses. Corneal examination. Using the transilluminator, the cornea should be examined directly and at various angles for defects, loss of clarity, changes in the curvature, or changes in size. Opacities should be characterized by their shape, number, texture, and location. Examination of the following intraocular structures is best completed in a darkened room. At this stage of the examination, the lights should be turned off. The iris and pupil. The iris is best examined before or while waiting for pupil dilation. The clinician should examine the pupil size and shape of the iris, and it should be examined for changes in color or texture, for stability, masses, adhesions, also known as synechia, or atrophy. Anterior chamber. The anterior chamber is the space between the cornea and the iris, and it should be assessed for clarity and depth. This is best achieved by using the direct ophthalmoscope as a light source in a dark room. The ophthalmoscope is turned up to full light intensity and set to the smallest round beam. The light is held 1 centimeter away from the corneal surface while the examiner views from the side to look across the anterior chamber. In a normal animal, one should note a reflection off the cornea, a dark space behind the corneal reflection, which is the anterior chamber, and then a beam of light traveling through the lens from the anterior to posterior lens capsule. The anterior chamber contains aqueous humor and is normally visualized as a transparent black space between the posterior cornea and the iris or lens. When the eye is inflamed, breakage of blood aqueous barrier occurs, and uveal blood vessels will leak protein and cells. When the protein content of the aqueous humor increases, the aqueous humor becomes cloudy and visible, such that when a beam of light is shone through the cornea, light will be taken up by the cloudy aqueous humor and result in a hazy beam of light connecting the corneal image to the beam of light traveling through the lens. This cloudiness of the aqueous humor is known as aqueous flare. Lens examination. The transilluminator is used to examine the lens for clarity, size, shape, and altered position. Retroillumination will aid the clinician in examining the lens and identifying lesions. Dilation aids in differentiation of nuclear sclerosis versus cataract and will enable the clinician to appreciate an aphakic crescent if present, in case there is lens subluxation. Vitreous examination. The space between the lens and the retina contains the vitreous. The vitreous is normally a gel-like consistency and clear. Occasionally, vitreal opacities, such as persistent hyaloid remnants, vitreous degeneration, inflammation, hemorrhage, asteroid hyalosis, and retinal detachment, may be noted via retroillumination. Ophthalmoscopy. Ophthalmoscopy is also known as fundic examination. It is used to examine the vitreous, optic nerve, retina, and choroid, and is the final step of the general ophthalmic examination. Ophthalmoscopy is performed in a darkened room through a dilated pupil. It is important to make sure the light source being used is not brighter than necessary when performing ophthalmoscopy. Too high of a light intensity may contribute to an uncooperative patient. There are two methods of ophthalmoscopy, direct and indirect. For indirect ophthalmoscopy, a focal light source and typically converging 20-diopter lens are used to create an upside-down and reversed virtual image of the fundus. Two forms of indirect ophthalmoscopy exist, binocular and monocular. For binocular indirect ophthalmoscopy, a binocular indirect headset or ophthalmoscope is used as a light source. This is the technique utilized most commonly by ophthalmologists. Monocular indirect ophthalmoscopy is most commonly used in general practice and can be completed with either a handheld transilluminator and lens or a monocular indirect ophthalmoscope, i.e. a panoptic. To perform monocular indirect ophthalmoscopy with a transilluminator, an assistant is required to hold the animal's head and to help with eyelid retraction. Small animals should always be examined on the table in a sitting or sternal position. This allows the examiner to position him or herself comfortably at eye level or even slightly lower than the patient. This positioning is essential to obtain the tapetal reflection required to initiate fundic examination. A chair at the head of the examination table may be necessary to allow for such positioning. Large animals should be positioned such that the head is at eye level of the examiner. This may require an assistant to elevate the head in the sedated animal. To begin indirect ophthalmoscopy, the lens is held with the thumb and forefinger about 6 to 8 centimeters from the animal's eye, and the remaining fingers are placed on the animal's forehead to stabilize the lens and help retract the upper eyelid. Most lenses have a white ring on one side which identifies the side of the lens that should face the animal. The lens should initially just be held on the head and not in front of the cornea until the examiner is ready. To obtain a fundic image, the light, lens, and pupillary aperture must all be directly aligned with one another. To do this, the light source is stabilized next to or just below the examiner's eye to ensure that the examiner's eye and the light are in alignment. With the examiner sitting at arm's length away and a little lower than the animal, the tapetal reflection is elicited by shining the light through the animal's pupil. Once a good tapetal reflection is obtained, the lens should be lowered in front of the cornea and aligned with the light beam to obtain an image. Once an image is obtained, the lens can slowly be pulled away from the animal so that the image is maximized and fills the lens. If the image of the retina is lost, the lens is pulled away from the front of the cornea, but should still remain stabilized to the animal's forehead, and the examiner should reobtain the tapetal reflection and then replace the lens in front of the cornea. To fully examine the fundus, the examiner needs to learn how to slowly move laterally, medially, dorsally, and ventrally, all while maintaining complete alignment of the light, lens, and pupillary aperture. Navigation with indirect ophthalmoscopy is usually the biggest difficulty while learning the technique, as one has to move opposite the view desired. Monocular indirect ophthalmoscopy can also be performed with a handheld ophthalmoscope versus a transilluminator. This special ophthalmoscope optically corrects the upside-down and reversed image for the examiner, allowing for a relatively easy fundic examination. The magnification provided is more than when the transilluminator is used, but less than that of the direct ophthalmoscope. To perform binocular indirect ophthalmoscopy, an indirect headset is used as a light source. The patient and lens positioning is the same as for monocular indirect ophthalmoscopy with a transilluminator. The head-mounted light source permits both eyes to be used for the examination, which allows for binocular vision, thus creating depth perception. This allows the examiner to better interpret fundic lesions. The headset also frees up the examiner's hand to allow for better positioning of the animal, its eyelids, and the lens. Direct ophthalmoscopy technique. A direct ophthalmoscope consists of a power source whose light is directed via a mirror or prism into the animal's eye and then reflected back to the examiner through a lens in the ophthalmoscope. The resultant fundic image is direct, upright, and magnified approximately 8 to 25 times in our companion animal species. The numbers visible on the rotating dial of the ophthalmoscope indicate the strength of the lens that is in place, expressed in diopters. Most animals' fundi are in focus at 0 or -2 diopters. The plus lenses, represented by black or green numbers, will converge light, bringing lesions elevated from the surface into focus. The negative lenses, represented by red numbers, will diverge the light and bring lesions depressed from the surface into focus. For a direct ophthalmoscopy, a darkened room is required and the light source should be set at the largest circle and the diopter setting to 0. The ophthalmoscope is then placed against the examiner's brow while looking through the viewing port at the tapetal reflection. The tapetal reflection is located at a distance of approximately 0.5 meters. Once the tapetal reflection is located, the examiner moves to a point approximately 2 to 3 centimeters away from the patient's eye to focus on the retina. To avoid interference between the patient's and examiner's noses, the examiner should use the left eye to examine the animal's left eye and the right eye to examine the animal's right eye. As I have mentioned, there are some essential differences in the ophthalmic examination in large animal species. The ophthalmic examination in large animals should ideally take place in a darkened stall, stocks, or examination room to minimize distractions and interfering reflections. After the distant and neuroophthalmic examinations have been performed, the animal should be sedated with a short-acting sedative, such as intravenous xylazine at a dose of 0.5 milligrams per kilogram. And an auriculopalpebral nerve block should be performed to provide paresis of the orbicularis oculi muscle. The auriculopalpebral nerve block partially paralyzes the motor aspect of cranial nerve 7, the facial nerve, and therefore decreases the animal's blinking strength. To perform the block on both eyelids, 2 25-gauge needles, a 3 ml syringe, and 3 ml of 2% lidocaine without epinephrine are required. The auriculopalpebral nerve block can be performed at several locations, but there are 2 main sites that are most commonly used. One possible site for injection is where the nerve exits the skull beneath the ear. Just anterior to the base of the ear is a natural depression that is just caudal to the ramus of the mandible at the ventral edge of the temporal portion of the zygomatic arch. Although not palpable here, the auriculopalpebral nerve emerges subcutaneously from within this depression. To perform the nerve block at this site, a 25-gauge needle is inserted to the hub in this depression and a syringe with 3 ml of lidocaine is attached to the needle. The syringe is then drawn back to check for blood, and if free of blood, 1.5 ml of lidocaine is slowly injected per side. Another possible site for injection is where the nerve traverses the zygomatic arch of the facial bone. Here the nerve can be strummed under the skin, just dorsal to the mid-portion of the zygomatic arch. This is shown in the figure as number 2. The skin above the nerve is tented, and a 25-gauge needle is inserted subcutaneously to the hub. The syringe with approximately 3 ml of lidocaine is attached to the needle, and approximately 1.5 ml of lidocaine is slowly injected per side. Be careful when infiltrating the lidocaine for nerve blocks. Hold the syringe to the needle hub and inject slowly. The lidocaine is relatively thick, and if injected too rapidly through the small needle, the needle will detach and spray everywhere. Part 2. Ancillary diagnostic tests. When an animal is suspected to be blind, ancillary means of vision assessment should be employed. These include the maze test and visual tracking. For the maze test, obstacles are set up in an examination room through which the patient must navigate. The obstacles can include anything from chairs to equipment to garbage cans. The maze test should be performed in both light, photopic, and dim, scotopic conditions, and if the test is being performed several times, readjustment of the obstacles is recommended to avoid memorization. The maze test may also be performed with one eye covered to assess unilateral vision. Animals with compromised vision will bump into or trip over objects, or in many cases, show reluctance to move. It is important that the animal rely on their vision to navigate the maze, and therefore voice commands should be avoided while performing the test. For visual tracking, a cotton ball may be dropped across the animal's line of sight to help assess vision. An animal with vision will usually follow this stimulus. A cotton ball is recommended as heavier objects may cause significant air movement or noise, resulting in a false positive test. Cultures. Occasionally, ocular surface culture samples may be necessary to determine the presence of pathogens. Corneal culture is indicated in all cases of complex corneal ulceration. The clinician should directly culture the corneal lesion and submit this sample for aerobic and anaerobic bacterial culture and sensitivity. To perform a corneal culture, a pre-moistened culturette swab is used to swab the corneal lesion while the eyelids are held open and away from the cornea. It is important not to touch the eyelids or conjunctiva with the culturette swab, as this can contaminate the sample. Cytology. Conjunctival or corneal cytology is indicated for chronic, unresponsive, or severe corneal or conjunctival lesions. Samples are typically collected after topical anesthesia and can be collected with various instruments, a cytology brush, or more often just the non-cutting end of a sterile scalpel blade, can be used to scrape the lesion to collect samples. The samples can then be transferred to a clean glass slide, air-dried, and fixed with a variety of stains. Tear film breakup time. The tear film breakup time is an assessment of tear film quality versus quantity, which is assessed with the Schirmer tear test. To perform this test, the clinician applies a drop of concentrated fluorescein stain onto the cornea and immediately closes the eyes to prevent blinking. Using the blue light from a biomicroscope or direct ophthalmoscope, the eyelids are opened, and the time is recorded from lid opening until the thick green stain, i.e., the stained tear film on the cornea, is observed to break up or evaporate. This breakup is observed as dark spots appearing in the otherwise green stain. The normal tear film breakup time in the dog is reported to be 19 to 20 seconds. Nasolacrimal cannulation and flushing. In patients with chronic epiphora or mucopurulent ocular discharge and a delayed or negative Jones test, nasolacrimal cannulation and flushing should be performed to rule out disease of the nasolacrimal system. In most dogs, this procedure can be readily performed under topical anesthesia with or without head loops to magnify the puncta. To perform the procedure in small animals, a 22 to 24 gauge soft-tipped intravenous catheter or a lacrimal cannula is attached to a 3 ml syringe filled with saline. The catheter is passed into the upper and lower lacrimal puncta in a medial direction, and with gentle pressure, the puncta are flushed. To prevent kinking of the catheter, it is important that the eyelids remain taut and that the cannula is parallel to the canaliculus. In a normal animal, fluid should emerge from the opposite punctum and out the ipsilateral nostril. Some normal dogs will elicit a prompt swallowing reflex, which indicates patency to the nasopharynx. Nasolacrimal flushing in the horse is performed in a retrograde fashion through the nasal punctum. The nasal opening is visible at the ventral mucocutaneous junction of the external nares. If necessary, an assistant can illuminate the inside of the nostril with a light source to aid in visualization of this opening. A small amount of topical anesthetic ointment or gel can be applied around the distal nasal opening and to the end of a number 8 French flexible feeding tube for lubrication. The rounded end of this tube is fed approximately 5 centimeters into the nasal opening, and a finger is placed over the cannulated nasolacrimal orifice to maintain the catheter in place and to prevent back leakage of the irrigation solution. A 12 to 20 cc syringe filled with saline is then attached to the feeding tube, and the fluid is slowly injected into the nasolacrimal duct. If the duct is patent, the saline will be observed to drain from the upper and lower lacrimal puncta. This concludes the description of the general ophthalmic examination and ancillary ophthalmic tests in companion animal species. For more information on ophthalmic disease and therapeutic intervention, consultation of specialized ophthalmic texts is recommended.